aorta and the medial end of both the clavicles. If the spinous process is in the midline and both the clavicle medial heads are seen on either side, then we can confirm that it is not rotated. The benefit of taking a view that is not rotated is that there will be no false assessment of chamber enlargement. It is also important that we take a very good deep inspiratory film on standing. When you take a proper film, you can see at least 5 ribs anteriorly and 10 ribs posteriorly. If it is less than 5 ribs anteriorly, it means the inspiratory effort was not good. Also, if you see more than 7 ribs anteriorly, it means that the lungs are hyperinflated, the patient may be COPD, and we may have to look for changes of cor pulmonale. For proper assessment of a chest X-ray, as far as a cardiologist is concerned, we should have a PA view. Now, to confirm that our X-ray is proper PA view, it has to be taken in erect position, not in bedridden ICU patients. The vertebral spines will be very prominent in PA view, whereas in AP view, the bodies are more prominent. We have to make sure the scapula are clear of the lungs, the clavicles should be horizontal, and the gas bubble in the fundus of the stomach should have a clear air fluid level, and the bubble should not be in the antrum. If we take an AP view, then it is quite common that we feel there is an apparent cardiomegaly. And in PA view, there should be overriding of clavicle and first rib. So all these findings will tell us that we are looking at a PA view. And always, as a cardiologist, to get more ideas out of our chest X-ray, it should be a PA view which is not frustrated and taken in erect posture with deep inspiration. It is also important that the exposure of the X-ray is optimal. Now, I'd say that an exposure is normal, the vertebral bodies should be just visible at the lower part of cardiac shadow. Now, when we look at an anterior view of the X-ray, the structures we see on the right border of the heart from top to bottom includes SVC and the right atrium. The right ventricle more or less does not form either the left border or the right border in an anterior view. And when we go through the left border of the heart, we see the prominent aortic knuckle, which is the distal end of the aortic arch, and then below it the pulmonary trunk, and below it the left atrial appendage, and below it the left ventricle, and then the cardiac apex. When we look at the lateral view, this is what we see. The anteriormost structure would be the right ventricle, and from it will arise the pulmonary trunk, and running above the pulmonary trunk would be the ascending aorta and the arch of aorta, and above it would be the plain shadow of superior vena cava. And behind the right ventricle would be the left ventricle, and the left ventricle would be drained into by the left atrium, which is obviously the posterior most structure in the cardiac structure. When we are asked to comment about an X-ray, we should quickly have an idea about all these: inspiration, PA view, exposure, rotation. 4 things quickly you assess, and then we start commenting. The first comment is to see whether there is cardiomegaly or not. So for that, you have a midline along the spinous process, and from the outermost point of the right border of the heart, you draw a horizontal line to this midline. Also from the outermost point of the left border of the heart, you draw another horizontal line to this midline. This would be B, this would be A, and we also draw plural lowermost, outermost space, either side points, line C, and then we calculate A plus B divided by C. If it is more than 0.55 or more than 55% of this length, then we say it is cardiomegaly in adults. Of course, in newborns, there is a slight margin. You can go up to 0.6. If the patient has some emphysema, then if you want to look only at the absolute values, then it should be more or less 15 or 15.5 centimeters in males, and in females, obviously, it will be slightly lesser, 12.5. It is very common that if we assess an AP film, we have a false identification that a patient has cardiomegaly even if he doesn't have. Other causes of apparent cardiomegaly includes obesity, pregnancy, ascites, and other skeletal abnormalities. Next, we come to the right atrial enlargement. To assess or diagnose a right atrial enlargement, we have both vertical and horizontal criteria. Now, vertically, if right atrium occupies more than 3 intercostal space, or if it is more than 50% of the right heart border, we can consider right atrial enlargement. There is also a horizontal criteria which says if from the mid-vertebral line, the border extends to more than 5.5 centimeter, or from the vertebral border, it extends to 3.5 centimeter, we can consider it is right atrial enlargement. Let me go to next. Now, this is an example of how we have identified this patient having right atrial enlargement. The midline across the spines we draw, and then this is definitely more than 5 centimeter, and we can know that this patient has right atrial enlargement. Obviously, when you see a patient who is having right atrial enlargement on chest X-ray, we consider such diagnosis as core pulmonary or pulmonary hypertension, tricuspid valve disease, either stenosis or regurgitation, Epstein's anomaly, atrial septal defect, wherein a large shunt of blood comes from left atrium and enlarges the right atrium and the right ventricle along with the pulmonary artery. And patients with dilated atria obviously may have atrial fibrillation. And it is very common that patients with dilated cardiomyopathy have right atrial enlargement. From right atrial enlargement, we move to left atrium. Left atrium enlargement, the findings would include a carinal widening more than 75 degrees. The left bronchus gets elevated. The left border of the heart gets straightened. You see the what so-called shadow within shadow or double atrial shadow, which are of different grades. And of course, when the LA enlarges too much, it will shift the descending aorta to the left and push the esophagus to the right, which obviously will be seen only on barium solo. Let us do an example X-ray. You can see that this patient has a carinal widening that's more than 75 degrees. And as part of it, the left bronchus gets pushed upwards. It is very important that we note that the left atrium is the posterior-most structure of the heart. So whenever it enlarges, it can only enlarge further posteriorly and superiorly. And because of this, you have the widening of the carinal angle, the pushing up of the left principal bronchus, and the left atrial appendage will be projecting out here a little bit, causing the straightening of the left border of the heart. And if you look carefully, you can see the double atrial shadow, the shadow through shadow. And sometimes when the left atrium enlarges quite a lot, it may even cross over the right atrial shadow. This is an example of the left atrium pushing the esophagus as seen well in barium swallow. Very rarely you can have aneurysmal left atrium as seen in this X-ray, where the left atrium enlarges so big that you think there is huge cardiomegaly. Coming to ventricular enlargement, there are two measurements of academic interest. One is Rigler's measurement. Rigler's measurement, you take a lateral view of X-ray, you follow the IVC, and where the IVC joins the cardiac shadow, you mention it as J point. Then you go up another 2 centimeters, mark the point X, then you draw a line horizontally to the cardiac border, posterior cardiac border, that would be Y. And then this length is called A. Now, Rigler's measurement, this measurement is normal people less than 17 millimeters, and in abnormal cases of ventricular enlargement, especially left ventricular enlargement, the left ventricle will get enlarged more posteriorly, and then the length will be more. So it is usually when we are given X-rays, it is very difficult to measure these measurements. However, it is of academic interest. But for practical purpose, we need to know that whenever the left ventricle, which is the posterior ventricular chamber on lateral view, gets enlarged, it gets to tend to move more and more posterior and downwards. So it will more and more encroach near the vertebral body, and sometimes in cases of huge left atrial enlargement, especially in left anterior oblique view, you can identify them even crossing the vertebral bodies. Yet another measurement for academic interest would be the so-called EYELER'S ratio. Here, where the diaphragm and the cardiac shadow meets in the lateral view, you mention it as point B. And from there, you draw a line to the sternal border, that is A, and you draw another line to the vertebral body and meet there, it is called point C. Now you see this ratio, AB by BC, normally it is less than 0.42. What happens when the left ventricle gets enlarged? This border becomes like this, more and more posterior and more inferior. That means this B point will keep moving more and more this way, and that means the ratio will become more and more. Now let us see what happens on right ventricular enlargement on PA view and lateral view. For right ventricular enlargement in PA view, you see that the cardiophrenic angle is acute. But we should also note that sometimes in clockwise rotation of the heart can cause the RV to move more and more laterally and occupy the left lateral border, pushing the left ventricle more and more posteriorly. But identification of right ventricular enlargement is always best done in the right lateral view. In that, you can see that there is obliteration of the retrosternal space, and as the right ventricle becomes more and more enlarged, the height of this obliterated retrosternal space becomes more and more, and the shadow becomes more and more dense. As far as PA view is concerned, we have already discussed the left ventricular assessment in lateral view. In PA view, whenever there is left ventricular enlargement, the left cardiac border becomes more and more enlarged, more and more convex, and gives rise to obvious cardiomegaly. The border of the left cardiac border, left cardia, it dips into the left dome of the diaphragm, and you get an obtuse cardiophrenic angle instead of an acute angle as you see in RV enlargement. Also, the apical segment will be rounded as seen in this X-ray. Now on lateral view, as we have already discussed, the left ventricle will enlarge more and more posteriorly and more inferiorly. And if you are exactly measuring, there will be values that are abnormal in both Rigler's measurement and EYELER'S ratio. LAO view is not commonly taken in X-ray unless we specifically ask for it. But in fluoroscopy, in catheterization lab, we very frequently use the left anterior oblique view when we are doing coronary procedures. And we can very clearly see that as the left ventricle gets enlarged more and more posteriorly, this posterior border of the cardia or the left ventricle becomes extended more and more and more. And radiologically, very often people even classify them as mild enlargement, moderate enlargement, or marked enlargement based on whether this border is encroaching into, covering, and crossing over the vertebral body. Next terminology we would be using while assessing a chest X-ray would be pulmonary venous hypertension and pulmonary artery hypertension. Now, there are certain normalcies which we need to assess when we see a chest X-ray. Now, we need to see that on the right side, next to the right border of the heart, we see the right descending pulmonary artery proximal portion before the bifurcation. Now, the right descending pulmonary artery proximal to the bifurcation should be about 17 millimeter. Anything more than that is dilated right pulmonary artery. And if you are looking at the PA view in erect position, the blood flow to the base of the lung is more than that of the apex of the lung. And the size of the vessel in the base is more than the size of the vessels at the apex. Now, you cannot measure the vessels at the left base because the heart covers them. So we always look for the basal vessels more or less on the right side. And on the upper part, the upper lobe veins are very, very less prominent. Also, if you look at the flow distribution, around the hila, the blood vessels are of adequate size, and when we move more and more peripherally, the vessels are tapering. And the distalmost 1/3, the vessels are very, very diminutive. Now, pulmonary venous hypertension, we can have a crude idea of the LA pressure or the pulmonary capillary wedge pressure by looking at an X-ray. Of course, there is small variation of the values for the pulmonary capillary wedge pressure or LA pressure based on whether it was an acute onset of the disease like acute pulmonary edema or a chronic progression of the disease, as you see in patients with mitral stenosis whose LA gets progressively enlarged and then develops slowly increased LA pressure and increased pulmonary capillary wedge pressure. But more or less, it has been staged into 4 grades, wherein the earliest stage, the X-ray evidence progressively worsens, and we will see what is happening. The normal pulmonary capillary wedge pressure is less than 12. That is what we see in normal people. So that is normal X-ray. Whenever the pulmonary capillary wedge pressure or the LA pressure goes more than 12, the upper lobe veins start to get prominent. So whenever you suspect a pulmonary venous hypertension or increased LA pressure, the first thing you look for is prominent upper lobe veins. It is also called redistribution of blood flow and cephalization, antler sign and all, because it resembles the antler's horns. It's basically due to interstitial edema, and there is also reflex vasoconstriction of the arterioles that makes the vessels more prominent. Now, when you see these findings, we can presume that the LA pressure has increased from 12 to 15. In the next stage, you see such worser findings like curly lines, interstitial edema, pleural effusion, and all. Now, one common thing that we see is the so-called peribronchial cuffing, which is showing as if there is increased thickness of the bronchus. It is actually due to interstitial edema, and this suggests that the pulmonary capillary wedge pressure or the LA pressure has moved from 15 to 20. Also, if you see curly A, B, or C lines, it also suggests that the pulmonary capillary wedge pressure corresponds to about 20. Now, coming to curly lines, curly B lines, they are actually seen at the base of the lungs. They are more or less 1 to 2 millimeter thick, and they always run perpendicular to the pleural surface from this edge and towards the costophrenic angle. It is basically due to fluid accumulation in the interlobular area. It's mostly lymphatic. It is very important that as a radiologist, or when you see the X-ray, as a physician, you identify these curly lines because they invariably mean that the patient has significant pulmonary venous hypertension and the LA pressure corresponds to more than 20. You also see curly A lines, which are actually dilated anastomotic lymphatic channel between central and peripheral lymphatic. They are seen like sun rays from periphery to the hilum. They are also very commonly seen in patients with pulmonary venous hypertension. Curly C lines are end-on views of curly B lines. Now, when the LA pressure further worsens, that means when it goes above 25, then things really become bad. You can see obvious alveolar edema, ground glass opacities, bilateral diffuse bat wing appearance, cotton wool opacities, and X-ray will look like this. This means that the patient has been having very high LA pressures and is probably critically ill and needs ventilatory support. Coming to the term pulmonary artery hypertension. Now, it is important that you draw a line from the left border of the heart to the aortic knob, which is the most prominent first curve on the left border of the heart. Most of the times, the pulmonary bay or the pulmonary curve is seen well inside this tangent that we have drawn. However, as pulmonary artery begins to become dilate due to pulmonary artery hypertension or due to increased flow, this shadow will slowly encroach into this red line and crosses over. Let us look at the image on the right. The pulmonary artery bay is very full and it has already crossed the tangent drawn from the aortic knob or aortic knuckle to the apex of the heart. Now, to say the patient has pulmonary artery hypertension, it is very important that you look at a few findings. One, you look at the prominent main pulmonary artery and proximal left pulmonary artery. That is, there will be prominence and it will cross over this line. The right descending pulmonary artery will be very prominent and dilated more than 17 mm. And the pulmonary vessels will be dilated proximally. But if they are very thin and cannot be followed beyond the distal, onto the distal 1/3 of lung vasculature, that is called peripheral pruning. And whenever you see peripheral pruning, it means it is hypertensive pulmonary artery hypertension. That means there is increased pulmonary vascular occlusive disease. There is yet another term. Sometimes there can be hyperkinetic pulmonary artery hypertension, wherein the patient do not have peripheral pruning. These patients will have pulmonary artery hypertension but no increased pulmonary vascular occlusive disease. It is the increased blood flow that is causing the pulmonary artery hypertension. Such scenarios, we use the word pulmonary plethora. Pulmonary plethora means increased pulmonary blood flow. Let us say, for example, an ASD patient with a large ASD and a large shunt from left to right, but there is no increased pulmonary vascular occlusive disease. That means the patient has not developed any features of Eisenmenger physiology. Such patients will have increased pulmonary plethora, a dilated pulmonary arteries, but no peripheral pruning. So, to say pulmonary plethora, we see that these patients will have a prominent pulmonary bay, a prominent right descending pulmonary artery. There is increased pulmonary blood flow and ground glass like appearance, and there are dilated and tortuous pulmonary vessels. And every time you see a bronchus and a pulmonary artery, they obviously go close to each other. The pulmonary artery is bigger, slightly bigger than the accompanying bronchus, and the right descending pulmonary artery will be bigger than the tracheal diameter. Also, whenever there is increased pulmonary blood flow, you can see a lot of end-on vessels, and the end-on vessels will be more than at least 3 of them you can see in one lung field, or at least 4 or 5 of them in both lung fields put together. Whenever you see this kind of picture, it means we use the term pulmonary plethora, increased pulmonary blood flow, very commonly seen in patients with shunt lesions, example ASD. Now let us come to another term, pulmonary oligemia. Now, pulmonary oligemia, as we all know, simply means reduced pulmonary blood flow. So there are many findings that support the term pulmonary oligemia. If you look at the pulmonary bay, you can see that there is a very small prominence or almost no prominence, or we use the term empty pulmonary bay, because the pulmonary arteries, proximal main pulmonary artery and the proximal left pulmonary artery is so not dilated. We can see that there is an emptiness there. And the pulmonary blood flow we have to assess once we see the empty pulmonary bay. Let us see this X-ray. The pulmonary blood flow is so diminished that it gives the appearance of hypertranslucent lung fields. So whenever we see a hypertranslucent lung fields, it means there is pulmonary oligemia. In other words, distal pulmonary blood flow is diminished. If the pulmonary bay is empty, but the lungs are not hypertranslucent, that means that the PA blood flow is not prominent. However, the lung parenchyma is getting blood flow through some other source, either through a PDA or through collaterals from the aorta, especially in congenital heart disease, which we call as MAPCAS. Next structure we would like to evaluate would be ascending aorta. And in ascending aorta, you see the smooth curve, and sometimes it is seen as a right border of the heart, especially if it is dilated. And if you trace it distally, this curve, you know that it very well goes to the aortic knob. Now, aortic knob means it is a junction of the arch of the aorta and the descending aorta. Now, how to identify if the aorta is dilated or not by looking at the aortic knob? You look at the tracheal shadow, and then you measure this length. It will give you X-ray wise some idea about the aortic dimension. It is very important that we look at it carefully, because very often ascending arch of aorta aneurysm may be identified as superior mediastinal mass and unknowingly may send for CT or guided biopsy. It may not be done by them, because as soon as they do CT with contrast, they know that it is from the aneurysmal aorta and not otherwise. Now, whenever you see the aortic knob or the aortic ductal prominent, it means that there is probably uncontrolled hypertension that has been long-standing, or some aortic valve disease, or some disease of the aorta per se, or the aortic media, like in cystic medial necrosis or aortic aneurysm. Now, sometimes you see extensive cardiomegaly, especially in pericardial effusion. So, how do we identify that? There will be obviously cardiomegaly. It will give a rounded globular appearance with very sharp edges here. The cardiophrenic angle will become more and more acute as the effusion goes on increasing, and the pulmonary vascular markings will become more and more oligemic, because as the pericardial effusion increases, we know that there will be collapse of RA and RV, and hence there will be diminished filling of the right ventricle, and hence obviously the pulmonary blood flow will be less. Now, it is very common that we will be at times confused between large pericardial effusion versus dilated cardiomyopathy versus multivalvular heart disease, especially combined valve regurgitant lesion versus Epstein's anomaly. So, based on how you analyze the X-ray, we have to carefully dissect the X-ray and identify what is the cause of this pericardial or this huge cardiomegaly. Constrictive pericarditis is yet another common diagnosis. When we take an X-ray, we should take in both lateral and PA view, and you can see that the right border of the heart is very commonly straight, and in lateral view you can see lot of calcium along the pericardial aspect. And to diagnose constrictive pericarditis by X-ray, very important that you take both PA and lateral views, because sometimes if you take only PA view, previous MI with calcified LV aneurysm may also show evidence of calcium, but we can confirm that it is along the pericardial border in lateral view, not in the ventricular myocardium. It is very commonly identified on fluoroscopy because you can see cardiac in constant motion, whereas the pericardium is mobile. If you are shown an X-ray of a patient containing sign of heart disease, first of all, you look at the pulmonary blood flow, decide if it is increased or decreased, then you look at enlargement, whether it is RVH or LVH. Based on that, we can narrow down our differential diagnosis to one of these as given in the chart. Now let's try to see this patient's X-ray. This patient, as we already know, shows evidence of huge cardiomegaly, and probable LV effects based on this and this, because shadow is moving more and more posteriorly. There is also the cardiac angle, which is 575 degrees. There is an elevation of the left principal bronchus. There is a straightening of left heart border. There is also right atrial enlargement. There is also prominent right descending pulmonary artery. There is prominent upper veins. So, together with all of these, we can conclude that this is probably the X-ray of a patient with dilated chambers. It could be dilated cardiomyopathy, or it could be a patient with multivalvular heart disease. So, based on the clinical findings, we can narrow down the diagnosis and see if the X-ray is consistent with the clinical findings we have already had. Another patient X-ray, look at it, you know that this patient has significant cardiomegaly. There is calcification at the level of both pulmonary artery and aorta. Calcification along the aorta is noted whenever there is long-standing uncontrolled hypertension patients, especially elderly patients, those who have higher disease. But it is uncommon to see calcification in pulmonary artery because the pulmonary artery are not exposed to very high pressures. So whenever you note calcification in the pulmonary artery, always consider an Eisenmenger patient, or a patient with severe pulmonary artery hypertension, or a patient with some metabolic disease because of excessive deposition of calcium in various parts of the vasculature. This patient also has a prominent right-listening pulmonary artery, and then there is increased ground-glass appearance suggestive of heart failure along with other minor prominence. So this patient has evidence of both heart failure, calcified aorta and pulmonary artery, which means that he has disease of both left and right heart and both are failing. Yet another patient, you can see that there is significant cardiomegaly. There is very prominent right-listening pulmonary artery. The aorta is more or less fair sized, but there is a very prominent pulmonary bay, suggesting there is an enlarged main pulmonary artery and proximal left pulmonary artery. And here the shadow is not very clear, not have a lateral view. So we are not very sure whether it is, and there is overlap of breast tissue as well. So we are not very sure whether it is RV or LV enlargement. However, there is increased pulmonary vascularity, and you can even follow the pulmonary vasculature into the distal 1/3 of the lung parenchyma. So all these put together, recurrent lower respiratory tract infection, after the clinical examination, we may conclude that this X-ray belongs to a patient with pre-tricuspid significant shunt more than 2:1 and increased pulmonary blood flow or pulmonary plethora and no evidence of pulmonary hypertensive disease or pulmonary vaso-occlusive disease. This patient's findings or X-ray findings is consistent with a large pre-tricuspid shunt that is amenable to closure and no evidence of pulmonary artery hypertension. This X-ray belonged to a tetralogy of fallow patient, and he had allowed to and fro murmur on clinical examination. Now, when you hear a loud to and fro murmur or a seesaw murmur in a TOF patient, you always consider TOF with absent pulmonary valve. And whenever there is a patient with TOF and absent pulmonary valve, there is unobstructed flow of blood from RV into the PA, which causes massive dilatation of the pulmonary arteries. That looks like Mickey Mouse ears. And also there is massive dilatation of the right ventricle because there is a majority of the blood that is pushed into the pulmonary artery regurgitates back into the right ventricle. So very often, classically, this is one case where the TOF patient will have large right ventricle and the right ventricle is prone to fail. Now, other causes of aneurysmal dilatation of main pulmonary artery may have to be considered when you see an X-ray like this, which includes idiopathic dilatation of pulmonary artery, primary pulmonary hypertension, and Eisenmenger. Classical X-ray that is kept for most of the exams, you can see that this patient has minimal or mild cardiomegaly. There is absent pulmonary bay. There is acute cardiophrenic angle, which suggests that the apex is formed by the RV. And if you look carefully, you can see that the trachea has an indentation on the right. That means it is a right-sided aortic arch. We can also conclude that the patient's pulmonary vascularity is near normal or slightly less than normal, which means that the pulmonary vascularity is not normal and the patient may be symptomatic. This patient will be requiring surgical correction. Now let us assume this is the X-ray of a patient who is having hypertension, young male, and continuous murmur. Of course, we consider coarctation of aorta as our first clinical diagnosis when you come across such a scenario. And when it happens, you always look for few signs which includes rib notching or erosion of the lower border of the ribs posteriorly, especially from ribs 3 to 8. These are mainly because of aneurysmal dilatation of the collaterals that help blood to flow from the pre-coax segments to the post-coax segments. It is because of this that we do not find these rib notching in ribs 1 and 2, and it takes a few years for the rib notching to develop, and you do not see this rib notching in the first 1 or 2 years in children. It's also important that we identify the reverse E or the 3 sign, where at the location of the coarctation there is a narrowing on X-ray. Now, it is very common that we see many patients who has undergone cardiac surgery with prosthetic valve. And obviously, the presence of the sternal sutures tell us that the patient has had a thoracotomy and an open heart surgery. And when you are seeing prosthetic valve, how to identify which prosthetic valve it is? Now, you may take either the lateral view or the PA view, and very often you draw a mental line from here to the hilum. And the aortic valve will be seen in profile in and around that line, and the mitral valve will be seen very close to it but not profiled. If you see the lateral view, the aortic along this imaginary line, the aortic valve will be seen above the line or on the line, and the mitral valve will be seen below the line. Obviously, it is logic, isn't it? When the left atrium is the posterior-most structure, then the mitral valve will be draining the blood from left atrium to the left ventricle, and from there it goes into the aorta. The RV is the anterior-most structure, and hence the pulmonary valve will be seen somewhere here, and in PA view it will be seen somewhere close to the pulmonary bay. And the tricuspid valve, almost always the prosthetic valve will fall on the midline, or it will be seen as the lowermost prosthetic valve if patient has multiple prosthetic valves, and in lateral view it will be very close to diaphragm. Yet another method to identify which is type of prosthetic valve you are having. Draw 2 lines like this, identify the 4 quadrants. The mitral valve will be more or less lying in this quadrant, the pulmonary valve in this quadrant, the tricuspid valve in this quadrant, and aortic valve is not very clear to say because it varies. Lateral view. Draw a line to the hilum, the one draining the posterior-most chamber LA to LV is the mitral valve. This is a mechanical prosthetic valve, a tilting disc valve. You can see the disc tilting there, and obviously just close to the mitral, anterior to it, would be the aortic valve. This is also a tilting disc valve. This is also a mechanical prosthetic valve. You can see the prosthetic, the sternotomy sutures as well. Now, suppose you see the ball in cage valve. The ball is made of silastic material, so it is not very clearly seen always unless you are seeing it in fluoroscopy. However, you can see the cage very clearly, and the direction of the cage will very clearly tell you the direction of blood flow. Let us say in this case, the blood flows from the left atrium, the ball moves forward and helps in the flow of blood from the left atrium to the left ventricle. So we know that this cage is a mitral valve cage. Same way, the ball moves forward and helps the flow of blood from the left ventricle that is below to the aorta that is above. So we know that this valve is aortic valve, ball in cage, prosthetic, mechanical. Sometimes you see an X-ray like this with a device. Now, this is not a pacemaker because we can see that there is increased thickening of this lead in 2 areas. One is here and another one is here. That means these are shocking coils. This coil is called the RV shocking coil because it's inside the RV. This coil is called the SVC coil because it is in the SVC, and this is the ICD, implantable cardioverter defibrillator, and it is lovingly called the CAN. So we have the CAN, the SVC coil, and the RV coil that will identify ventricular tachycardia and then shock. So this is the X-ray of a patient who has had ICD. We can also see evidence of heart failure in this patient as cardiomegaly, very prominent aortic knuckle, hilar prominence, and prominent upper lobe veins. We look carefully for obliterated costophrenic angles, which suggests that the patient has some pleural effusion and obviously patient has some decompensated heart failure. This is yet another patient. We know that this is not ICD because this patient has one lead here, and this is a patient who has had a dual chamber pacemaker. Sometimes you can see one more lead coming all the way from the device and going to the lateral wall of the left ventricle. This is called the left ventricular lead. It is not actually inside the left ventricle. It is inside the posterolateral vein of the left ventricle. That device would then be called a triple chamber pacemaker, otherwise called cardiac resynchronization therapy device, CRT device. If there is an ICD lead on the RV lead, you can see there are thickening in two areas, then it will be CRTD, otherwise it will be called CRTP. Hope this helped you a lot in evaluating, analyzing, and understanding the patient better when you see an X-ray next time. However, if any clarifications are needed, I'd be happy. Thank you very much.
Thank you, Dr. Tom, for a presentation.